my name's Graham Worrall, and my potted life history goes as follows. As you can tell from my suave accent, I grew up in the United Kingdom and did my medical training and residency there.
And you were?
I was very fortunate during my family practice residency in the UK to accidentally meet a beautiful girl from Newfoundland on the train, and she gagged me, bound me, and brought me to Newfoundland, struggling only slightly. And so after that, I first went into rural practice in Newfoundland. This was not an academic practice. It was a salaried community practice, 2 doctors looking after 3,000 people.
Wow.
Which wouldn't happen these days. I did that for 13 years, and during that time I did several research projects, and I was fortunate enough to be able to go away to McMaster University for a year to obtain a master's in clinical epidemiology. After 13 years, I discovered I'd done sufficient research and publications to apply for and obtain a faculty position in Memorial University of Newfoundland, and moved to one of their rural teaching sites in Whitburn, where I became the center for a tiny research establishment called the Center for Rural Health Studies. I remained there for 15 years, doing a fair amount of research, and 2 years ago, receiving my old age pension, I retired from full-time academic work, and now I spend my time occasionally doing 1 or 2 day locum in rural hospitals and clinics that are desperate because of dying, moving, or sick physicians.
Okay, well, it's nice to have you. Thank you for agreeing to this. First of all, we'll talk about your research career. How did you become interested in research?
Well, not exactly screaming and yelling the way most residents are brought into contact with research when they're obliged to do a study as part of their residency, as was I, but it seemed rather interesting. And I remember it very well because it taught me a few very valuable lessons about doing primary care research in the real world. As a resident, I performed an audit on the 4 physicians in the family practice I was training with. What I did was to see how compliant with or on time the family physicians were with their appointment system, because I'd have observed that 98.6% of patients arrived for their appointment in the office on time or early. So my question was, well, patients are certainly punctual, are the physicians? The answer is, not really. Of the 4 physicians, 1 arrived on time and kept to the schedule. So all his patients were seen pretty much on time. 2 of the 4 arrived and started on time, but as their clinic went on, they slowly became behind schedule. So their first patients were seen pretty promptly on time. Their last patients were seen up to 20 or 30 minutes late. The 4th physician, the black sheep in the family, routinely, I observed these physicians over a month, arrived routinely about 30 minutes late for his clinic. And as if that were not bad enough, to be confronted with half a dozen fuming patients at the beginning of the clinic, he got later and later as his clinic went on. So he started 30 minutes late. By the time he finished, he was an hour or sometimes an hour and a half late. After I did this little audit, I presented the results to the physicians in question. Their office staff, of course, this was no news to them, and the physicians said, "Oh my God, I didn't realize I did that. I will change." A year later, I had another look at them. Nobody had changed. The punctual guy was still punctual. The unpunctual guy was still unpunctual. So the valuable lesson that this taught me was, even when confronted with solid evidence in the real world, people's behavior is unlikely to change much. This prevented an awful lot of heartache in subsequent research with real people, real patients, and real physicians in the future. That was one valuable lesson from this very first research project, which cost zero money, just the time and the effort and the paperwork. No computers in those days.
Mm-hmm.
I also learned, lesson number 2 was, you have to suck up to the doctor's office staff, or ancillary staff, or support staff, or practice nurses, whatever they are, because if you don't do that, they won't help you, and the data will never be gathered. If you're nice to them, they're very helpful. And office staff, as you know, are very good at telling doctors what to do. They can put data sheets in front of the unwilling physician with a pen. Fill this in. That's lesson 2. Lesson 3 was when I decided to try and publish this in the journal of the British College of General Practice, and it was successfully published after about 6 rewrites and 1.5 years. So I realized it looks easy to publish, but it's not. It's a lot of hard work, a lot of revision, a lot of patience. And the 4th lesson was, from start to finish, this research took about from conception to publication took about 3 years. You have to be patient. Researchers have to believe in deferred gratification. Now I realize, of course, 3 years was that from conception to completion of publication was very quick, but at that time I didn't. So the first thing I ever did taught me several valuable lessons.
Sounds like it. That's great. Can you tell me which, of all the studies you've done, which has yielded findings that have most had the potential to influence primary care delivery?
That's a very difficult question, because as I've already implied, people don't change very easily. Let me think. I may come up with an answer if I try and review the studies I've done. In reviewing, a few years ago I did a presentation in the family medicine department with a title such as 30 Studies in 30 Years. Yeah. Looking back at the various things I'd done, and I was not surprised to find out that many of the studies that we did were observational studies or case control studies, the sorts of things that much family medicine research is involved with. And of these 30, I think I'd only ever done 5 proper randomized trials, which is what we should be doing, and which I think is a weakness of family medicine research. There's too much navel gazing and looking at patients' charts and doing audits, but even worse, looking at our own behavior and sort of asking ourselves how we feel and how we behave. I think it's much of family medicine research is too narcissistic. So, having said that, I would say the 2 studies that to me produced the most valuable results were, firstly, the very first true trial I did myself, single-handed, while still in rural, non-academic practice, was a trial of, which asked the question, does it make a lot of difference whether the doctor uses sterile technique to repair a simple skin laceration? Because in rural practice, people are always coming in the people who might go to emergency departments in the city come to the family doctor's office in rural medicine. So people with skin lacerations, which require anywhere from 2 to 10 stitches, but you're not too worried that the nerves or the muscles or anything serious is cut. I was taught, and so were the people I were working with, that one used full aseptic technique. One scrubbed, one masked, one gloved, and one used nothing but completely sterile technique and dressings. And I thought to myself, well, do you really need to do this? So I devised a 2-arm randomized trial. One arm was the standardized, as we're taught at medical school and residency, sterile technique, and the other was, oh well, maybe I'll wash my hands and I'll try not to spit into the wound, but I'll not take too much. I'll keep it clean with soap and water, and I'll just use the regular sutures. The randomization, I took some marbles from my son, and 25 blue marbles and 25 red marbles in a bag. I closed my eyes and took a marble. That was my randomization technique. No computers in those days.
Right.
And within a year, it was a rural practice. Within a year, I'd repaired 50 lacerations and compared the results. Not surprising to me, the totally sterile technique didn't do any better than the soap and water technique. This was published. I think it was one of the first true trials from family medicine ever published in Canadian Family Physician 25 years ago. And again, it's taught me some valuable lessons. It is possible to do true randomized trials in primary care, and we should be doing more of them. It also taught me a question, well, maybe lots of things that we're taught in residency and medical school are not necessarily true and don't necessarily apply to family medicine. So, I became interested in methodology. After 10 years as a rural physician, the generous government of Newfoundland allowed me to take a fully paid sabbatical year. I went to McMaster University and did the clinical epidemiology, and then I learnt, of course, several important things. Firstly, the small trial I'd done was underpowered. As you know, if you don't have sufficient people in each wing of a trial, there's a possibility that your negative result, in this case, didn't make any difference. The negative result may in fact be a false negative. There could be a difference, but you don't have enough power. So epidemiology taught me about things like power and randomization. It also introduced me to the Cochrane collaboration for the first time, in which, as you know, this is a vast collaboration of academics and researchers with the noble goal of setting up a database of all the good quality evidence, mostly clinical trials, on every intervention we do, which, not surprisingly, has come out with the result that of every 100 things we do in medicine, not just primary care medicine, but all medicine, 25% can be shown to be really beneficial. 25% can be really harmful. The 50% in the middle, well, we really don't know whether they do much good or much bad. They probably don't do much harm, but they probably don't do much good. This made me far more critical of most of the things that we were doing in primary care. And in a sense, it made me a bit of a therapeutic nihilist. I started prescribing less, asking why I was doing what I was doing. It made me a lot more skeptical about doing new things and prescribing the latest medication. And it made me firmly resolve, if possible, never to talk with a pharmaceutical company representative for the rest of my life. The other thing, I'm hoping now that nobody's bothering to use really just keeping their hands clean, but not using sterile technique to repair lacerations. That was a teeny trial. A few years later, having moved into an academic setting and realizing that research is done in teams, I took part in a large trial involving care of the elderly, because I'd done a couple of observational studies of cognitive function in elderly people, looking at, for example, do people with diabetes have impaired cognitive function compared with those who don't? Because, as we know, you have diabetes, it affects your peripheral nerves, your feet start feeling tingly and you can't move, you can't tell the difference between hot and cold, you have a peripheral neuropathy. Diabetes causes autonomic neuropathies. Things go wrong in your belly and chest. So it seemed to me, well, if the diabetes is affecting the nervous system, surely it's affecting up in the noggin, and do people with diabetes actually perform as well on cognitive function tests? And we did a couple of small studies that showed that they don't. The difference is not very great, but it's there. So just another one of many strikes against those unfortunate people who have diabetes. But this stimulated my interest in care of the elderly, and as you know, there's a tremendous fear that the grey wave will wash over the country, overwhelming the health and social care systems. And there's a tremendous move to try and find ways to keep people in the community. The idea is keep them at home, keep them out of institutions. I mean, that's become a sort of apple pie issue in gerontology. So a group of researchers, mostly at university, mostly at Memorial University, but one in Alberta and another in BC, we decided to answer the question, which home care advocates are very keen on, is if elderly people in the community are given comprehensive, thorough, multidimensional functional assessment. In other words, you test, can you do this? Can you do this? In the middle, are you thinking straight? Are you acting straight? Can you balance? Can you see? Can you hear? Can you dress? Can you shop? Can you think? Etc., etc. If these assessments are done comprehensively at a relatively early stage, by which I mean you're not young old, you're sort of middle-aged old, you turn 80. Will these comprehensive assessments identify problems which can be addressed and improved, and hopefully not only make people function better, but keep them out of the the geriatric dumping grounds, where my wife, by the way, has an advanced care directive to put a bullet into my head rather than go into one of those places. This is not a bias, it's just a personal preference. So seriously, what we did was identify a lot of people in the community living apparently successfully in their own homes from 80 years and older. Anywhere between 80 and the oldest was 101.
Mm-hmm.
And we had a team of research assistants do all kinds of tests, and needless to say, a certain number of problems were identified. One group was said, look, we've discovered you're a bit hard of hearing, you can't manage on your own, you need help with your medications. Can we help you? So they were given the offer of ongoing professional help. The other group was, which we called the self-efficacy group, was said, well, we've identified certain things that seem to be problems or potential problems. What are you going to do about it? You're a grown-up.
Mm-hmm.
So one group was the self-efficacy group, the other was, we'll hold your hand and lead you through the system group. We assessed them, and then we followed them for years.
Mm-hmm.
And what we wanted to see was, well, which group did better in terms of death rates hospitalization rates, and in particular, institutionalization rates.
Mm-hmm.
Well, what a surprise. We found out at the end of the time that all our well-intentioned, very careful testing, going out and looking for problems, did not make any difference whatever. In fact, the group that was helped finished up in institutions slightly more often than the group that wasn't. It wasn't a statistical difference. So this, to my mind, was an important negative trial which told us that, people are grown-ups. We don't need to meddle with them too much. Let's not be, this is not the Salvation Army. This is the medical care system. Let's not be do-gooders.
Okay.
So, and similarly, the laceration trial said, don't do as much. And I would say that the emphasis of my research is do good quality research, do classical trials, and expect them to be negative, giving us evidence that a lot of what we do, we don't need to be doing. Am I a nihilist? Am I a realist? You be the judge. Next question, please.
Okay.
Going on a bit, eh?
Is there a question in family medicine research that you think should be explored that hasn't? Is there something?
Well, there are so many. What surprises me that because family doctors see everything, do everything, there are just so many questions, and I can't really say that one area is more important than the other. But if you like, I can tell you about my hobby horses.
Your hobby horses?
My hobby horses, okay. My hobby horse for the past decade has been acute respiratory tract infections in primary care.
Mm-hmm.
The coughs, the colds, the earaches, the sore throats, the sinusitis. This accounts for a fifth to a third, depending on the time of the year, of all work family primary care physicians do. It's a massive area of our work, and you know what? It's been barely studied.
Really?
Whereas, other areas, don't talk to me about how much work has been done on fibromyalgia, for example.
Okay.
Lots. And the average family physician may see 2 or 3 people with fibromyalgia in his or her entire career.
Right.
But, colds, 5 a day in the winter. So my hobby horse was that, having examined, again I was lucky enough, the joys of academic life, to be able to take a sabbatical year to go spend it in Australia,
mm-hmm.
in Melbourne, with the Cochrane unit there. And I spent a lot of time looking at the literature on primary care with regard to acute respiratory tract infections, how common they are, how many see doctors, what patients think, what doctors think. To put it in a nutshell, far too many patients were seen, and far too many doctors were prescribing antibiotics. In the olden days, before you were born, Stephanie, in the olden days, the doctor said, you've got a cold on your chest. Do not worry, it will get better. Or, you have a cold in your head. Do not worry, it will get better. But in most countries of the world at the moment, the doctor will say, you have acute bronchitis, take these antibiotics. Or, you have acute sinusitis, take these antibiotics. So, my hobby horse was that viral illnesses, predominantly viral illnesses, were being diagnosed as bacterial illnesses, which gave family physicians a license to prescribe unnecessary antibiotics. So I started doing research just personal research as to whether you could reduce antibiotics. And I saw 100 people with earaches and didn't give them antibiotics. You know what? They all got better.
Right.
100 people with sore throats was another case series. 100 people with acute coughs. Most of them coming to my office because they've been conditioned to expect antibiotics.
Right.
they didn't get them, they went away grumbling, and they all got better, apart from the few who died. Sorry, strike that. And so the question is, well, patients like them, family doctors like them, are we doing any harm? And the answer is probably, because the rare case of the number of antibiotics you have to give, for example, let's look at coughs, could be pneumonia. Let's give them all antibiotics. The number of antibiotics that you have to give to prevent one case of bad pneumonia is, and the subsequent side effects from the antibiotics, is far greater than the effects of not giving them.
Right.
Simple of number needed to treat versus number needed to harm. So a recent research project involved, well, how can we get doctors? We can't stop them writing doctors are like automata. They just can't stop writing prescriptions. And, well, if they're going to write prescriptions anyway, why don't we ask them to write not immediate prescriptions, but delayed prescriptions? That's when the doctor says, you've got a cough, Mrs. I don't think it's anything serious, but I can't be sure. I'll give you some antibiotics. Why don't you take this prescription, wait for a couple of days. If you get better, don't use it. If you're not getting better, or if you're getting worse, don't come and see me. Take the antibiotics.
Right.
So that's a delayed prescription. And there's good evidence that if doctors give patients a delayed prescription, they won't use it. A lot of them won't use it because they'll get better anyway.
Right.
So the doctors can still continue writing the antibiotics, but far fewer of them will cash in with the savings in cost and side effects and the development, a worldwide problem, development of antibiotic-resistant organisms. So the study that a couple of colleagues and I did was, well, we know, other people have done the work, that if you give people delayed antibiotics, 50% of them will never cash that prescription.
Okay.
So my question was, well, does it make any difference if I say, today's the 2nd of November, I'm not sure what you've got, I think you're going to get better, but I'm not sure, I'm going to give you a prescription. Do I date it today, the 2nd of November, in which case you say, I don't believe that physician, I just go around the corner and date it today and say, don't take it for 2 days if needed, I can go around the corner and cash it, or do I give you one dated the 4th of November on the 2nd, explaining you can't, even if you want to, you can't get this for 2 days.
Right.
In other words, you delay the delay. So we did another little trial. Guess what? It didn't make any difference. If a doctor gives a delayed prescription, far fewer antibiotics are used, but it doesn't really make any difference whether the delayed prescription is post-dated or not. A little study, but a trial, gave some evidence.
Right. What's been the most rewarding part of being a researcher?
The most rewarding part of being a researcher is the tremendous amount of time it's kept me away from my wife. Oh, sorry, strike that. Okay, the most rewarding part of being a researcher is the fun and the intellectual activity. So much of routine practice, like anybody's job, is just bread and butter, day after day, hardly conducive to boredom and burnout. Whereas I rapidly found that doing research, and I cannot understand, is it just me? I cannot understand why most physicians can't see how interesting it is, because firstly, looking at the evidence, you have to use your brain.
Mm-hmm.
Then you think of the research question, you have to use your brain. Then you have to design your methodology, you have to use your brain. Then you apply for funds, and that drives you crazy. And then you actually have to do the field work, and luckily some research assistant, if you get the money, does all the hard yakka, and they have to put up with the doctors. But you meet interesting colleagues and interesting patients, and you do a lot of things that you never did before. It adds spice, it adds variety, it adds intellectual interest, and mostly it's fun.
Okay.
But you have to be a bit weird to enjoy that sort of fun. Nerds of the world, unite!
Okay. Family medicine research, as a group, we need to get more recognition. We need to traditionally have had to fight for
Yes.
funding and that sort of thing.
The specialists in the colleges, we're off their radar screen.
Yeah.
Yeah.
So what do we have to do to get the attention of decision makers, funders, and of the public, and express to them how important this
We
is?
have to propose and do more good quality research. And I've already said we've got to stop looking at our navels. We have to stop doing surveys. We have to stop doing attitude studies. I'm not saying we probably have to stop doing case control studies. I don't think we should stop doing cohort studies, because general practice with the same doctor following a group of patients, hopefully for decades, general practice primary care is ideally situated for doing prospective cohort studies.
Mm-hmm.
Most of what we know about medication and management of diseases comes from a secondary or tertiary or higher level care. I mean, we don't really know how effective in the long term most of our interventions are in our population. We
Right.
know that, these drugs work on cardiac patients in coronary care units, but Joe Blow in the community, smoking like a till, going out into the woods every weekend, is the effect. In other words, we need to do a lot of research in, is it worth it? We need to be very critical about what we do. Good quality research means more cohort studies, but in particular more trials, more clinical trials, which are harder to do, more expensive. We need to develop sufficient doctors in larger networks, because you do a large trial to power it up. I mean, the days are gone, it's not like the first case of penicillin being used in meningitis. All you needed were 5 patients with meningitis and 5 bottles of penicillin. That was your trial. Now we're talking about drug A for hypertension versus drug B. They both work, but which works better over the long run?
Right.
The difference is going to be tiny, maybe 5%. You need large numbers of people, lots of doctors, lots of patients, networks. So we need better quality research, unfortunately more expensive, longer lasting. So we need to do that kind of research, and we need to start publishing it. I mean, I would like to say in the Canadian Family Physician or Annals of Family Medicine or the British Journal of General Practice, but really what I mean is New England Journal of Medicine, British Medical Journal, sorry.
Mm-hmm.
How can we get younger family physicians and our residents to do more? I don't know. It seems to be a self-selecting group. It would be nice to say that every one of us researchers is extrovert and charismatic, and that way we would accrue many disciples. But that's not the case, as we know. Tend to be sort of a little obsessive compulsive, to say the least. And some of us have absolutely no fashion sense at all. And the answer is just try and identify them when we can, and try and lead by example. But no magic answers.
Okay.
Most doctors hate doing research.
Yeah. What do we need to say to decision makers and funders? How do we get across to them how important family medicine research is?
Well, it's a hard sell. All I can say is, and as you know, steps have been made in the Institutes of Health Research. Slowly, the profile is coming. I think we just have to be more rigorous. I mean, if you apply for funding for crummy research, you're not going to get it, and they'll just say, what are they doing, these family doctors? It's just not rigorous enough. The trouble with that is, if one is intellectually rigorous and critical with the younger doctors and the residents, you tend to put them off, because you say, well, that's not the way to do it. Think. So it's a paradox. How can you encourage with the one hand and be critical and inspiring with the other? Can't say.
Tough sell. Tough sell.
Who wrote these questions anyway?
I wonder.
You.
Tell me about. I have only time, I think, for a
Yeah,
couple
sure.
more questions. A mentor. Is there a mentor who stands out in your mind, or were you self-taught?
Self-taught, I would say. Yeah,
Self-taught.
self-starter.
Okay. And I'm going to ask you a couple of personal questions.
I'm
If
sorry,
you-
I'm busy tonight.
If you hadn't been a physician researcher, what kind of career would you have taken on?
Okay. Yes. Another interesting anecdote rears its head.
Perfect.
He groans to one side. When I was a medical student, I had the fortunate accident, stroke of fortune of being in a severe car accident. I wasn't the driver. It was I have an identical twin. That's why I seem to have done twice as much research as anyone else.
Oh,
My identical
I see.
twin. He was the driver and we had a car crash. It wasn't his fault. As a result of that, I finished up in hospital for 4 months. Strung up, just like in the movies, with my leg in a sling and on traction. I was able at that time to observe hospital medicine, as it were, from the inside, in depth.
Mm-hmm.
And I pretty rapidly decided I'm not going to be a hospital doctor. And then the career choice was family medicine or community medicine. And I was sort of inspired by those fellows, that stopped the typhoid epidemic by spiking the Broad Street pump and so on. And so for a time it was a toss-up between community medicine, because clean water has done far more for the health of the world's population than antibiotics and medicines have ever done. So it's a toss-up between community medicine or family medicine. And family medicine won because, you were seeing real patients. The idea of a life as a doctor without seeing real live, breathing, red-blooded, multiple orifice patients. But if they said, you can't be a family doctor, I would be a crusading community medicine activist. Maybe with the United Nations, bring clean water to Africa. Why on earth? Why aren't we immunizing the entire world's population? So spend money on immunizations, not on the latest third generation of heart medicines.
Right. Okay.
So I don't want a quintuple bypass when I'm 85.
Right.
Okay? Right.
What famous researcher would you like to meet? Famous in the past, Canadian, worldwide? Is there somebody?
Not in medicine, in any researcher in anything?
Anywhere.
Okay. Thomas Malthus.
Okay, tell me about Thomas Malthus.
He's the guy that said the world's population will outgrow its food supplies. I'd like to meet him, but this was about, I think it was 17 or 1800 something. And the world's population then was about 500 million. His idea was, we're already straining the resources. If it gets to 1 or 2 billion, we're all going to die of starvation, war, famine, and rapine. As you know, yesterday the world's population hit 7 billion, was it?
Right.
We're still here, so I like to meet him and say, no, Malthus, you were wrong. And I think that's a humbling thought, because whatever research we do today, a few years down the road, somebody's going to say, I don't think you got it quite right. It's a sobering and humbling message. Amen.
Very good. Thank you very much.
You're very welcome.
How interesting. Fascinating.
As you can tell, I don't take this stuff too seriously.